Good afternoon, Namibia. Welcome to the COVID-19 Communications Center daily update at 4 o'clock in the afternoon, focusing on the health sector and all things related to COVID-19 in Namibia. This morning we discussed a little bit with people who were able to give us information on how the residents of local authorities are dealing with COVID-19. However, this afternoon we're focusing on the health aspect of COVID-19 in Namibia, especially the approach to patient management during this crisis. Today I'm joined by Dr. Eric Zuban, who is the Country Director of the CDC Namibia. Thank you very much for joining us again as we give an update on today's topic, as well as Dr. Catherine Muwonge, who is the Case Management Focal Person of the World Health Organization. Thank you very much for being with us. And of course, Dr. Ishmael Kachitai, who is the Physician Specialist in the Ministry of Health and Social Services. Thank you very much, Doctor, for joining us. So the topic today really is about the approach to COVID-19 on patient management. Perhaps we could start with you, Dr. Kashitai. What is patient management? And from the aspect of COVID-19, what does it entail and how is it different from normal patient management with regards to diseases or viruses that are not as contagious as COVID-19?
Thank you, fellow Namibians and listeners, for giving me this opportunity. The important thing is actually, why did we choose that topic? We have actually been observing a lot of information going around since this media center was actually started. Some of that information was quite useful information, but there was also a lot of miscommunication and misinformation as well. And we felt, as the three of us here, as you have introduced us, we should be able to be in a position to answer directly to most of those questions. As everyone knows, currently we are sitting with over 2.5 million individuals worldwide who are infected by this coronavirus. There are around about 165,000 individuals who have actually died as a result of this year. So it is, and there is around about 212 countries which have actually been affected by this pandemic. So right from the beginning, one can actually see that this is a very unusual disease. We know about countries with which had very good infrastructure, countries such as Italy, Spain, to just give you an example. And those countries' health systems have literally crumbled down. So, which actually shows that this disease, this COVID-19 disease, is not something to be taken very lightly. It's a serious disease, and it's mainly being complicated by the fact that it makes people very sick, and it's very, very highly contagious. It's not something, although it's something like a virus, like a flu, there is a big number of people who have actually ended up dying. And for that reason, since this is a pandemic situation, it is quite important that we need to take a different approach than what we've been having. The most important thing is actually that if you differentiate it from other conditions, is actually that someone can actually have an infection and actually not notice anything. Indeed, if you look at the way how this illness comes, 80% of those who are affected by this disease have relatively mild symptoms, not symptoms which will actually take people to go to the hospital. So that's one unique way of this COVID virus. But the problem is actually that those individuals who have got a light disease, who have got a mild disease, have got a potential of actually passing this disease to other people, and this disease can actually, on the longer run, making those individuals sick and even taking their life. So there is a lot of differences with that. And even if one looks at the symptoms, the other thing is actually that most of the COVID symptoms can also mimic ordinary harmless conditions. Harmless in brackets, if I can say that they are harmless, because if you look at the ordinary flu symptoms which we have been having, and this is around about the same period of the time when we are actually having flus. People can easily underestimate it and just think that this individual is actually sitting with flu, but indeed he might be actually having this condition or allergic conditions like asthma, like seasonal hay fever. These are all things which are very relevant, especially in this rainy season which we had. So it's actually quite important to take a different approach since since the consequences of this disease is actually devastating. I will leave it at that for the time being.
Thank you very much, Doctor. Dr. Muwonge, maybe we could get a little bit into what this misconceptions or misinformation is around patients who have COVID-19. What does the average patient of COVID-19 look like? What is their immunity and so on? And how can people be rest assured that there is proper patient management happening with those who might be infected with COVID-19?
Okay, thank you very much for giving me this opportunity to join you here today. COVID-19, to begin with, is caused by the coronavirus, which is a new virus. But its symptoms are basically respiratory symptoms, like many other respiratory illnesses. So the difference, though, with COVID is that it's highly transmissible and has been declared a pandemic. As we have seen from many countries, many people have been affected and health systems have been put at strain because of the number of cases. Basically, and because it's a new disease, we found that it has affected mainly the elderly patients or people with comorbidities. And therefore, in that population, we need to be very careful about it. But having said that, it's really a new disease that is being, not a lot is known about it, and we are learning as we are going. So in terms of its immune response on the host, all these things are just being learned, and probably with time we'll be able to understand. But it's a new disease, so it's really complex.
Okay. Thank you very much, Dr. Muwonge. Dr. Thiupan, there is, as alluded to by Dr. Kashitai, that first of all, it's an infectious disease, and it has really taken over the world by surprise. Even the most prepared countries who had functional health systems have crumbled under the pressure. What is the outlook on the current patient management situation across the globe, more specifically even in Namibia? How are we coping? Are we coping well? Are we not coping? What are some of the issues there?
Well, it's a good question. I think if we look at the situation in Namibia, what we can be really happy about is that we had extra time before we started seeing our first cases. It was the middle of March before a case was diagnosed here in Namibia. That gave us some really precious days and weeks to get better prepared. As we watched this disease affect other countries earlier, they didn't have that opportunity that Namibia had to get a better understanding of the virus, to see what was working and not working around the globe. And so Namibia used that opportunity. The country was gathered, different ministries, different partners like CDC and WHO at the table advising and coming together to come up with a plan. That was really to Namibia's advantage. Then we started getting cases, and we knew we had to act immediately. And a lot of people were brought in for a national response. CDC doesn't have its own COVID-19 response in Namibia, neither does WHO. We're all unified. We're all here under the government's leadership, working together. So what this has allowed us to do is to be prepared. When we had the lockdown come in, we saw a decrease in the number of cases. We're still at 16 cases in Namibia, as Dr. Kashitai said. That number hasn't changed for over 2 weeks. So we can't know for sure that all transmission has stopped. We are expanding the testing to really get a better understanding. Is there transmission we're still missing? But in the meantime, we're having evidence that it's slowing down, that the lockdown is working. This very difficult situation the Namibians have found themselves in with the lockdown, it's for a good cause. It's making a difference. It's preventing more disease. So with that in mind, Namibia is able to not only take care of these 16 people and make sure they're getting all the medical treatment and support they need, but getting that healthcare system ready for what might come, trainings across the different regions about managing people with COVID, about testing, about intensive care, things that will be helpful in the future if we do see more cases arrive.
Thank you very much, Doctor. Viewers and listeners back home, we encourage you to call in. That's at the number 061 400 397, 061 400 397 to get you to ask your questions and any queries you might have around the health response to COVID-19 in Namibia. This session is specifically dedicated to you for you to ask those questions. As we get our callers in, Dr. Kashitaye, we have seen that reports around the world that there are alleged people who have recovered from COVID-19 being reinfected with the virus. Could you speak to us a little bit about how that is possible?
Again, Namibia is actually lucky that they have seen the experience of other countries. We know that this pandemic started off in China, to be specific, in Wuhan, in the province of Wuhan. And then we've also seen that pandemic spreading to countries such as South Korea. Similar question was actually asked yesterday here when they were referring to a specific group of individuals who were here in Namibia. The most important thing is actually, maybe which I can also just add is, when we're talking about patients in public, we don't really want to give any clues as to who is spoken about. Because this is a very strong stigmatizing disease. The individuals who are already there have actually been put in a difficult situation. And now, even mentioning them, we all know that we have actually gotten some numbers of that. And those numbers have actually circulated in the social media, and they're very easy to track down. And this could be, it's just my plea that we should really try to refrain from getting out clues which can actually give out identities of individuals. But nevertheless, this was actually discussed yesterday about a particular individual who tested, who was initially tested negative, and then he tested again, positive again. Now, the issue is actually that, yes, there were people from the previous countries with this pandemic, like, again, I will get out the Chinese experience, who were declared to be cured, who were negative. But then, within a very short while, they managed to come back again, being declared positive, who have actually become reinfected.
Doctor, we have a caller on the line that we have Tuya from Ongwediva. Tuya? Tuya?
Hello?
Yes, Tuya.
Yes, I can hear you.
Yes, you may go ahead.
Yes, I just wanted to ask the doctor from I think it's the CDC. He said that the lockdown is working. I would just like to ask, what does it mean that the lockdown is working if you haven't done any mass testing? If we say that even before the lockdown, there were no people dropping dead in the streets, and now they've locked down the people for basically no scientific reason, we have no curve. What does it mean the lockdown is working if 100 people violated restrictions? If there's one person who was tested positive but violated restrictions, if Wuhan opens their lockdown without a vaccine, what does it mean it's working? And then just the last question based on that, if you can please explain herd immunity, which is the excuse that many doctors are giving, that apparently if you get the vaccine, which is getting a form of coronavirus into your blood, then the country can have herd immunity. Does Wuhan have herd immunity or not? Because we have no new infection.
Tuya, so if I got your question correctly, you're asking if the vaccine is actually going to work. I didn't quite hear your last question.
I'm saying, right, he might answer by saying that herd immunity is what we need to wait for. That's why we must lock down the people. We need to wait for a vaccine,
yes.
Right? And so I'm asking, did Wuhan get a vaccine? If there are no new infections, what does it mean a lockdown is the best approach for us?
Okay.
How can they decide it's the best approach for us?
Thank you very much. I think it's clear now. It's a follow-up to the first one. Thank you. All right. Dr. Kashita, you were saying?
Just one other additional. On the follow-up on that question was actually that there were indeed, in South, from the literature which we have actually looked at, there were individuals who were infected where the test actually showed that they were negative at the beginning, and then within a very short time also became positive. So this is not an unusual experience that people are actually finding, that one individual might actually test today negative, and then tomorrow being positive. The difference is just that the issue is just that how do you really approach them? Do you release them and say that they don't pose a risk to the public or not? From the literature which we have gotten from the experience of the South Koreans, they seem to think that these individuals have got a low transmission rate and thus might not be a risk. But it's obviously not a chance which we can actually take with our limited resources here. That's why we have actually decided that should anyone actually test positive, having spent their 14 days in quarantine, then they will have to remain in quarantine under treatment until such a time that they actually are test 10 negative.
Twice.
Yeah.
Okay. Thank you very much, Doctor. Dr. Tube, there's a question to you that how is the lockdown really working if we don't have scientific evidence to prove that there could be a vaccine to be developed very soon? Around that, and that there hasn't been mass testing. So how is the lockdown working?
Sure, it's a good question, because I think people worry when they look around and they feel that we don't know what's happening out there. And it's true that we don't have a clear view of every person in Namibia and whether they've been infected or not. We are increasing the amount of testing that's happening day by day, and we are still seeing no new cases in the last couple of weeks. So the lockdown was intended to reduce transmission, and that's where I say that it's working, that we have evidence that we're seeing less transmission. We're identifying less transmission, even with increased testing, than before the lockdown. The idea of herd immunity is different. Herd immunity, the idea that so many people get infected, that they become immune, that the virus can't spread, that's not the short-term goal. For that to happen, first of all, we would need to know that after getting this virus, you become immune and unable to spread it afterwards. And we don't know that yet. It's a new virus, and we're still learning what does it mean after infection. Are you immune? Can you get reinfected? How long does that immunity last? Those are really key questions that we don't have the answers to. So the best thing we can do right now is really to slow down transmission, to better prepare our health system, to allow not just Namibia, but the global community to understand this virus better, understand what works well against it, understand and bring in more supplies to fight the virus. That's what's going to help reduce suffering, improve the well-being of Namibians. And in that way, we know things are on the right track. We still have a long way to go. This fight is not over by any stretch, but we have seen some progress, and there's some hope that this difficulty is paying off.
Thank you very much, Doctor. We have Soini from Aranda. Soini? Soini? Okay, now we've lost that caller. All right, as we have time for one more caller, perhaps, Dr. Muwonge, we can speak a little bit about, we have, of course, now in Namibia only 10 cases that are active cases, and those are I presume, the patients that we're managing in the country. Should we have an increase or further decrease of these cases, what would it look like with the operations and support that the World Health Organization is giving currently?
Okay, thank you. We have used this time when we have a slow in transmission and a slow in the number of cases to prepare, as Dr. Eric has mentioned. We have used this time to prepare, and we have worked together closely, CDC, WHO, and the Ministry of Health, to better prepare, first of all, the health system and increase on the capacity of the beds, capacity of human resource, training of the human resource, and WHO has been very helpful in that front, together with all the other partners, in trying to make sure that we prepare for the worst if it were to happen. So we have used that time to prepare, and we have scaled up in terms of bed capacity, in terms of human resource, training the human resource to make sure that they can be able to respond to the pandemic if it were to flare.
We also see that a lot of health workers in many parts of the world are actually becoming more infected, and that is, of course, making it harder to fight the virus, because those who are supposed to care for the patients, the ordinary patients like me, are then the ones being infected, and they will the one need caring. So in such a situation, are the three partners also prepared for such situations?
Yes, and actually to add on to what WHO has done, we have managed to bring into the country what we call PPE, personal protective equipment, to ensure that all the people at the forefront of this response are protected and prevent infection. Especially we have seen in other places in the world where health workers have been infected and have actually lost their life. So we have been very, we've been very key in that front and made sure that we prepare in that regard.
All right. Thank you very much, Dr. Muwonge. It seems we're not receiving any callers. I would like now to give the opportunity to our media practitioners here in the house to ask their questions to the panelists. I see you have a hand over there. You may come to the microphone. The floor is yours, ma'am.
Good afternoon, Esther Kamati, Namibia Media Holdings. My first question is for Dr. Eric. The CDC was working on a study to determine how many persons potentially could be affected by COVID. How far is this study? My second question is for Dr. Kachitai. You mentioned the process of recovery and testing positive again, if I'm not mistaken. I'm not sure if you meant somebody who initially tested positive and then who initially tested negative, and then went on to test positively. So I just need clarity on what you said earlier. And also I would like to know, is there such a thing as post-recovery check-up or so, or if somebody suspects they still could be positive for the virus, is it their responsibility to turn them in, or is there a way that the ministry can identify such cases?
Thank you very much. Do we have another round of questions? So we just take them all together. None? All right. Dr. Eric.
Sure, thanks for the question. CDC has just been providing inputs for the ministry's modeling. I think what you're referring to, we call modeling. We try to look at different scenarios to see how large could this outbreak be. If we do this intervention and it brings the numbers down versus if we don't do the intervention, the numbers go up. So those are the kinds of inputs that we've been providing for the ministry, different epidemiological models that they can use. And what we've seen, it's for the ministry to take the different models and determine which ones fit best here. But what we've definitely seen in other countries is without interventions to really increase the social distancing, if we don't do things to space people apart, if there are still large gatherings, if there is still business as usual, the models show in many countries more than half of the entire population being infected. So we know that this virus passes very quickly. And because we now see that even before you have symptoms, there's the possibility that you can be transmitting it to other people, it can especially move rapidly. So this is why that social distancing is so important. And Namibia has done well with it. People have really taken to these recommendations. Even in this room, I see so many examples of people using good hand hygiene, spacing each other out, covering their face when coughing, using their elbow. It is making a difference, and without that, the numbers could get incredibly large.
Thank you, Doctor. Dr. Kashitai?
Yeah. The most important thing is actually to know that different individuals have got different immune responses. If we look at the 16 cases which we had, we could actually clearly see that there were individuals who were sick, but within a matter of 7-6 days of having been under care, they started showing signs of recovery. Their fevers went down, their well-being improved 100% to the extent that then at that time, after 7 days, that we have opted to test them, and they tested negative continuously on 2 repeated occasions within 24 to 48 hours. Those were the individuals. And this is actually showing the different responses compared to the one individual who have again tested negative and then tested positive again. The issue is actually, since this is a new virus, people don't really know exactly what to make out of that.
Thank you, Doctor. We do have someone on the line.
Yeah.
Valerie from Windhoek?
Hello.
Yes, Valerie, you may go ahead.
Okay, I would like to know how prepared are we if the spreading is massive like the other countries? How prepared are we relating to the health workers? Do we have enough workforce to handle that pressure here in Namibia?
Thank you very much, Valerie. The question is very clear. Yes, Dr. Kashita, you may continue.
So that's what I was just saying, that unfortunately with this individual, he was being tested, and within a short time, he actually became positive. It's different. It's an issue of one could actually ask yourself, was this person reinfected or not? We don't think so, because for someone to get reinfected within a very short time, like within 24 to 48 hours, that seems to be a bit impossible. Mm-hmm. But the reality is, in this situation, this individual will still unfortunately, have to remain in quarantine and under treatment until after 7 days have actually passed, since they are all asymptomatic, since they don't show any symptoms. And then after 7 days, he will have to be retested again and see as to whether he has actually cleared the virus. Again, this actually depends on the individual immune responses. And unfortunately, different people will actually show different responses. And this is not just unique to the Namibian cases. In those COVID-affected countries, this has actually been reported. And again, the advice is actually from our side, we cannot release such a person into the public because we regard him as a potential infectious risk. And that's the reason why we have actually kept that individual still under our care.
Thank you very much, Dr. Kashita. Perhaps I will give this question from Valerie really in context here to all the panelists, that are we really prepared? And I think this has been a long time coming from every individual in the country, perhaps a mistrust of government's interventions. But considering that we have had only 16 cases, 10 are still active, and we have 6 recovered, no deaths, perhaps just to put the Namibian nation to peace with the fact that we are trying our best. Why are we really prepared? What are we doing specifically to ensure that should more people get infected, let's of course say that without hoping that, are we prepared? Are the ventilators enough? Are the healthcare workers prepared? Are they equipped? Perhaps I think there needs to be this type of reassurance, because this question keeps on coming up and that there seems to be doubt. So are we prepared, and how prepared are we? Dr. Kashitai.
Yeah, no. From our side, we are actually blessed that our government has showed a very matured response to this year. Our first case was actually documented on the 13th of March. Immediately, as soon as this information has actually gone up to the higher level, our president, in fact, acted very quickly. Mm-hmm. He followed the public health expert advice, and Then a state of emergency was actually declared on the 17th of March. My colleagues will correct me if I'm misplacing the dates.
That's correct.
17th of March, this was the state of emergency which was actually declared. And at the same time, there were a lot of things which were actually activated by the government as well. We could actually see that the various ministries were working tirelessly in terms of actually preparing themselves. The Ministry of Funds was actually activated, the Defense Force was also activated, the Ministry of Health was actually activated, the various groups actually went immediately at work, complementing the work of the Namibian Defense Force, which have actually set up that isolation facility or treatment facility, the hospital, the field hospital as they call it, at the airport within a very short time. And looking at the structure which they have also put in was very impressive to see that type of work from that side. The Ministry of Finance have actually they have made the right calculations and they have actually availed enough funds, realizing that this is actually a very exhaustive exercise. There is, for instance, we need to, just from their side, provision for masks, provision for personal protection facilities had to be made. And this is where the Ministry of Finance have also come in up there. And as far as from Ministry of Health, there were various response committees which were actually set up. I think we've got around about 8 leads. They are called pillars of leads of action, of which the case management committee is actually one of them. And this doesn't consist just of me alone. As you can see, the colleagues you are seeing here are actually part of the daily meetings which we have got. And very often, we actually spend time, day and night, to work out, even during the weekends, to work out certain things. And it's not only that, there is a surveillance team with the rapid response groups, which are also working on that tirelessly. If you can remember that there were individuals who came from outside, and realizing that they came from the high-risk countries, we decided to quarantine them. We decided even those who were actually discovered to be positive were tested, the test confirmed that they were positive, and then a lot of work went down on that, and it's still going on. There was a lot of surveillance which went around looking at the contacts, looking at the possible infectious risk, and those contacts were actually also looked at, and they were tested, and if they were negative, they were actually advised to remain in self-containment for 2 weeks, for a 2 weeks period, and they were monitored daily, and they are still being monitored. If we talk about all these 16 cases, we were not just talking about those 16 cases. Those 16 cases had at least some of their contacts, and those people are being traced up on a daily basis. We had to look, obviously the government have actually also invested a lot of money in terms of putting up quarantine facilities or isolation units, if you can call them that way. For those who were infected, they were actually put in isolation units. And for those who came from outside, who seem to have posed a risk of actually spreading this virus, were actually put in specifically, purposely made out lodges. We all know about that now, that, for instance, the group which went to the Hadab Dam, for instance. I can talk, I think, under correction, around about 300 people have actually been taken away, put up under quarantine facilities.
Doctor, let me pause you there. We have Tuya again on the line. Tuya?
Hello?
Hello, yes. Tuya?
Yes. I wanted to ask the doctor from the CDC. I wanted to say, you said that about herd immunity. Can a virus be destroyed? Because you said reinfection must be avoided at all costs. How can we avoid reinfection if we treat the virus with a vaccine? Meaning that the virus can never be destroyed unless the person dies. So I wanted to ask you, please, can you elaborate on that? Because the stories that we are hearing are somehow flawed and only being given to lay people, only because they they take your word for it that a virus cannot be destroyed. The reinfection is not a problem. Because
right.
it never leaves the body, right?
Thank you, Tia. You ask about whether or not this virus can truly be destroyed, seeing that there seems to be reinfection happening. So we'll address that as we move forward. Perhaps Dr. Kashitai could just round up as to what you were saying.
Yeah,
Please.
so just to round out, the fact that the government has actually been able to take care of individuals, of close to 300 individuals who have actually been put in special facilities at their cost, hosting them, putting them in various lodges and in various tourist facilities which were actually meant for tourists. You know the cost which is actually involved that, and the government has tirelessly availed funds to actually cut down this type of transmission rate. And then not only that, from our side as a case management, we've also been looking at the facility readiness. We can actually talk, there are different scientific modulations which one can actually make based on the experience of other countries. And we have looked at, for instance, I mean, if we have got a strike rate of around about 10%, saying that 10% of the country's population has actually been infected, then we are talking about around about 250,000 Namibians who will somehow be brushed off with this disease. And if you take that 250, around about 20% of those individuals will stand a chance of actually developing a severe illness, maybe 15% of that, and then 5% of that will develop a critical illness, which means that around about 8,000 of those individuals will require hospitalizations. And then if you look at critical care, we will also talk about around about 250 individuals requiring intensive care treatment. We are aware of these things. We're not sleeping around and looking at that. We are aware of that, and we have actually made projections on that. And according to those estimates, you can actually start looking at how many ICU beds do you need. We'll actually most probably run about, if one looks at that, we will actually say run about 737 ICU beds which will actually be needed, and another 200, ordinary 700 ordinary beds, and run about 200 ICU beds will be needed. And you can go on and say that how much protective gear do you need, how many masks do you need, all these things. And then you can also, with the same modeling, you can actually go and say that how many health professionals do you need, be it now doctors, nurses, or whatever it is. And because of that, we have actually then also gone and requested for volunteers. And under correction again, I could actually say that round about the ministry have actually approved over 2,300 individuals who will actually be recruited in the Ministry of Health Services to provide voluntarily services. Obviously, the arrangements are actually there. And these are different groups which are actually working on that. So there is a lot of activity which is going on there. We have looked, yes, we have looked at Commas, we have looked at Erongo, which are the most affected regions in the country. But the same model has also been activated through the various regional offices, the directorates which are in that. And they have also worked out a plan. And we have actually engaged everyone. We have been speaking to the private sector, the various associations, the medical associations for doctors, nurses, and critical care individuals have been activated. We've also looked at the private hospitals, all of them, to see how much can they actually contribute. So everyone has actually been working together.
Thank you very much, Doctor. I think that's a very specific and clear analysis. We have Martha from Rundu on the line. Martha? Martha?
Hello?
Yes, you can go ahead.
Hello. I just wanted to find out. My question is actually for the doctor from CDC. Why is it that we can't have, like when we had this HIV problem in the country, we were encouraged to go and test. Go and test so that you can know your status, so that you can know where you stand. Why isn't it the same with the coronavirus? Because I feel now, some people are asymptomatic. You might not have those symptoms, and you might be walking around like I see people are not really respecting the regulations. They are walking about like they want to. and you could be infecting other people, but you also don't know. So isn't it better if we could advise people to go and get testing like they used to do with HIV? And the other thing is, I wanted to ask also, the people in quarantine as we speak now, I think 300 or 400, I don't know, I'm under correction. Is it people who went to the hospital themselves that are not feeling well? Or is it people that came out from other countries that were quarantined? Or are there people that are also tested door to door like in other countries? Thank you so much.
Thank you very much, Martha. Perhaps we could get into answering, of course, the first question by Tuya around reinfection and whether or not this virus can truly be destroyed, even if we do get a vaccine, or because the vaccine is projected for 18 months from now and so on. At this point, how are we really going to contain this virus if it seems to be difficult to destroy it? And the question of, since most of our cases even now are asymptomatic, there could be perhaps the argument that many people might have the virus, but they're not showing any symptoms. So can we not encourage people to just go out there and get tested at the different health facilities? And lastly, that those who are in quarantine, are those people the ones who have already been tested? Those that are in quarantine, did they go to the hospital themselves, saying that they might be showcasing some of the symptoms? What is the profile of an average person in quarantine, basically? Yeah, so those are the questions. Dr. Eric.
Sure, yeah. It's a lot of questions, but they actually tie well together. And it goes back to one of our questions in the room a few moments ago regarding, are we really prepared here in Namibia? I don't think any country in the world right now would say we were 100% prepared for this pandemic. Every country has learned something after the fact and found ways they could be better prepared. But Namibia did have that good fortune of not being one of the first countries to be infected. Dr. Kashitai mentioned the airport facility, the mobile medical field hospital there. And I was looking at my calendar yesterday and I realized I visited there with the Minister of Health back in mid-January. That was 2 months before our first case arrived. So there was an opportunity to continue to prepare. And now we have these weeks where transmission is slowed down, where we can see that the hospitals are better prepared. We have more ICU beds than we had a month ago. Isolation beds, we have more ventilators, we have more personal protective equipment. If you have friends or family here in Namibia who are healthcare workers, like I do, like many of us do, they're safer today than they were a month ago from this virus. And so that time is worth it. I'm relating this to the idea of, can we really control the virus? We don't know what the future looks like. We don't know how many people will get reinfected. We don't know when a vaccine will come and how effective it will immediately be. But what we know is what's happening right now, and that by slowing down transmission, we're able to make Namibia safer. We're able to make our healthcare workers safer, especially our elderly and most vulnerable are safer right now. So the question of asymptomatics and can we all just go and get tested, because maybe we have it as well. That ties in also. The testing supplies are limited. You can imagine every country in the world right now wants these same testing supplies. The kits, the swabs, the liquid that the swab has to go in before it goes to the laboratory. These are in high demand. The more time that goes on, the more that's being produced, the more that's being shipped to places like Namibia. So these weeks where we're slowing down transmission are also allowing us to have a situation where more people can get tested in case there are asymptomatic people out there that we haven't identified yet.
Thank you very much, Doctor. Any responses from Dr.
Yes,
Mwanga?
I just wanted to add that we are, just like my colleagues have mentioned, we are better prepared than we were at the time the first case was detected. Now, preparing involves a lot of many strategies. It's not only preparing hospital beds and health workers, but it's also trying to understand the transmission potential of the virus and trying. We have also prepared ourselves in trying to slow the transmission. So we have prepared at many fronts. So it's not only preparing the bed capacity for when we have a whole lot of sick patients, but we've also made plans and preparation in trying to slow the epidemic by ensuring that our surveillance systems are doing very well, and we are able to detect early and isolate cases so as to reduce further transmission and cause a whole lot of patients who would have an effect on the health system. So we're prepared at many fronts.
Thank you very much. Before I give you a chance, Dr. Kashitai, is there any questions from the media? Yes, ma'am, the floor is yours.
Good afternoon. My name is Shamaine Gashihewe. I'm a journalist with a Namibian newspaper. I wanted to find out, Namibia only has 16 cases, which is a good thing, but I wanted to find out, do we have the intention of maybe taking part in clinical vaccine trials, or are we going to follow the current treatment regimen? And then in terms of reinfection, I wanted to find out how exactly is Namibia mitigating the issue of that, like the reinfection issue. And then when it comes to targeting testing, the Deputy Minister of Health this morning announced that 20 people were tested yesterday. How many were tested today, or how many samples have been taken today? And then I guess for us journalists as well. So would we need to self-isolate while we wait for the results? Thank you.
Thank you very much. As we respond to those questions, we have one more. Sir, very quickly.
Afternoon, Thierry, freelance journalist. I just have one question. I just wanted to ask, in connection with the numbers that we have so far, since we are getting more and more recoveries, would it be a sign that maybe we are starting to see the curve flattening, or maybe we're still far away from our peak? Thank you.
Thank you very much. So I think the questions are clear. Clinical vaccine trials, are we exploring that? Reinfection, what do you have to add there? Targeted testing, as well as, do we have a curve even at all, or are we having a flattening curve? Maybe Dr. Kashitai. Yeah.
I will take you quickly back.
Okay.
It's worthwhile mentioning that we have, at Windhoek Central, we have also built a facility which can actually take up to 10 intensive care unit beds. It's actually a COVID isolation unit, isolation ICU. So that is there. And that should be inaugurated anytime from now on, because we have inspected that unit. And at the same time, opposite Windhoek Central Maternity, there's also a 12-bed unit, isolation unit, which has actually been added on that. Just to show you that there's a lot of things happening. We're also looking at Ramatex, possibly should the pandemic really become worse. People are working around the clock to see whether there's no possibility of putting up over 550 beds unit as well. These are work in the background, just for people to just know that these things are happening. Okay, now coming back to those questions. You need to know one thing. If you test positive, persistently positive, you will remain under quarantine, because we cannot take that chance. It's a new virus, novel virus, as they actually say it. So those individuals who have actually tested positive will remain in quarantine until, and will be retested again 7 days later, until such a time that they finally become negative, because the risk and the odds are just too high. You must remember, we don't have those facilities which the Europeans have got. And the European systems were actually shattered. So we cannot afford to allow this disease to get into our hospitals. And thank God, there is no major hospital which actually had any of these cases yet, because we don't have those severe cases which require that. So that is basically that from that question.
Clinical vaccine trials?
The clinical vaccine trials, I think I will ask Catherine to deal with that, because she is WHO. They regulate those things.
All right,
Well,
Doctor. So
question was-
the question is Namibia considering taking part in clinical vaccine trials?
Well, that's a hard question to answer, but I'll give it a shot. So far, we only have 16 cases. And as you may know that we would require, more cases for us to be able to understand the immunity, responses. However, whether Namibia is willing to participate in a vaccine trial, I think that question is beyond me. There are other countries where the trials are being held, and those are countries where we've had, a large number of cases. So, yes.
Thank you.
Testing expansion.
Dr. Eric, would you like to
Testing
respond to
expansion.
something?
I
The
think-
curve, there was also the question about the curve.
Yeah, so our curve has been flattening in terms of the number of diagnosed cases. And of course, the follow-up question then is, but are we missing them? Are we not diagnosing them? And that's what we're working so hard on right now, is really expanding the number of people getting tested, going to the places where we think it's most likely that we would identify new cases to do testing there, so that we know if this flattening of the curve is an actual stopping of transmission, or is this just that we haven't identified those communities where transmission is happening? It's easy to miss people who are asymptomatic because they don't have symptoms. It's very hard to happen to test the right person without symptoms, especially if they're not known to have contact with someone or travel to a place with the virus. But we know that some percent of the people who get infected do have symptoms, and some of them get sick and need hospital care. So those are obvious early places to go to do more testing to see if we can find this virus in a place that we hadn't found it yet.
Okay, Dr. Kashta, would you like to add something? Perhaps also in closing, really, concluding remarks before we end of the discussion, just also looking at a comparative analysis, where we are at as a country and how we're handling the virus, and doing that comparison to countries that have really had struggled to handle the virus, even up to a month, 3 weeks or 2 weeks from the time the first case was diagnosed in that country. Yes, Doctor.
Yeah, in this current situation, I'm glad I'm living in Namibia and not elsewhere, because the way how we have gone about things, we seem to have actually taken the right steps. If you listen to the news, look at, for instance, examples of the president of Brazil, or you even look at Tanzania, where they didn't even embark on the lockdown. Those people started off with very few cases, which were run about for just like us, almost in the same time. They have literally refused to bring on the lockdown. And I think those numbers have actually exploded to such a high rate. So the measures which we have really taken are bringing us in the situation in which we are. The lockdown is always linked to the 14 days. It's a magic 14 days, and why? The main thing is what one needs to understand, that is actually even those asymptomatic, mildly infected cases where we expect them that they could even be the ones who are spreading this disease, they will, if you develop, let's say you become infected and you still don't show any symptoms, or you show very mild symptoms, it takes round about, for an average person with a normal immunity, it takes round about 14 days to clear that virus. And other people, who are severely infected might actually go up to 3 weeks, 21 days. So that's the reason why we're also linking the lockdown to 21 days, because in that situation, if you say 21 days, and you count properly to that, provided that you don't get people who are coming in and sort of seeding further infection, then we should actually be able to control this here. The issue of the testing expansion is basically main thing. They are limited, as Dr. Eric has actually said, there are limited testing kits available. It's either the kits
Worldwide.
or worldwide. Even what we are doing, we have, for instance, once you have gone out of quarantine, we will be testing you. Other countries are not even doing that. Once they have actually seen that you haven't had any symptoms for 14 days, they discharge you to go home on either self-quarantine for a week, and then they leave you. because
there is
and the main reason
monitoring.
is actually that there is a lack of testing kits. And if we say the pandemic in Namibia is going to peak around about June, potential of seeing the worst in June, by the time, if we start using all our testing kits, by the time when we reach that time, we will not be having anything. And this is the time where we might need to have them, because this is the time where you could potentially have seriously ill people. And then you are really in dire straits. And that's the reason why we relatively conservative to test people. Further on, just finally, the 16
concluding
individuals,
remarks,
the 10 individuals who are in quarantine are rather asymptomatic. They are free of symptoms. It's just a matter of waiting. Some of them are waiting to complete their 14 days, and some of them are those groups who are taking a bit longer to clear the virus. And I've already motivated why we are keeping those individuals up to the stage where they have actually cleared the virus. So the main thing is actually this is a very serious, devastating illness which deserves respect. So from the community outside there, we really want them to follow the measures which have been brought in, the hygienic measures, the social distancing, and obviously clearly if there are individuals who know that they are already at risk, they fall into the category of possibly having been infected, then they will have to come and actually help, because they might not have an infection, but they potentially could cause potentially harm by infecting people with weak immune systems and then causing their deaths.
Thank you very much, Dr. Kashitai. Dr. Catherine, just 1 minute.
Yes, I should say that we are lucky in Namibia that we seem to have contained transmission and only have 16 cases. We know that most of these cases were imported cases, and right now the borders are closed and air travel has been restricted. But we know that this cannot go on for so long, and at some point we will open the borders, we will open air travel, and we don't know what will happen at that point. So my point is that we need to remain vigilant, and we shouldn't relax, and we should carry on with the public health measures, just like Dr. Kashitai has mentioned, social distancing, hand washing, cough etiquette, and all those things. We should really ensure that we keep up.
Thank you very much, Doctor. Dr. Eric. Final remarks.
Yeah, I would just conclude by saying these are challenging and uncertain times for Namibia, for the whole world, and it's affecting everybody. My family lives here with me in Windhoek, and my sons, they play their games, and even with their toys, they talk about coronavirus and escaping it. It's affecting everyone. We never thought 2020 was going to look like this when this year started, but we're not without hope. And months ago, we could say we're not without hope because we know what works to protect yourself and your family from this virus. Washing your hands, covering your cough, staying away from people who are sick. But now we also have hope showing that what we're doing as a nation is helping. We're seeing signals that it's working, that these tough times can be changed, that we will get through this together. Usually I work on HIV. That's normally what most of my job is on. And Namibia is actually a leader in ending the HIV epidemic across Africa. Namibia is a model of how to do that. And we see some hope now. Namibia can be a leader in fighting this pandemic too.
Thank you very much, Doctor. Thank you very much to my panelists and the media practitioners in the house, as well as you viewers and listeners at home who have constantly been engaging us and asking us your questions, because really our role here is to give you factual information that's credible and authentic for you to understand how all the sectors and partners across Namibia are trying to fight COVID-19. So please join us again tomorrow at 10 o'clock as we invite the Ministry of Labour and Social Security to talk about how they're doing their part to assist all of us in fighting COVID-19 in Namibia. Of course, continue following the developments on our social media platforms, that is with both the Ministry of Health and Social Services and the Ministry of ICT on Facebook and Twitter, to continuously be informed about the developments around COVID-19 in the country. Do continue to join us. Join us tomorrow again when we hope to see you then. Have a blessed day.